I titled my presentation, Unfamiliar, Controversial, and Undiagnosed Disease, The Doctor's Eye View. So I want to talk to you as a doctor broadly construed, but ultimately my perspective from a child abuse pediatric background will come through and hopefully will add to the discussion. I heard a little bit of the last discussion and I recognize that there is significant overlap, although maybe a slight difference in perspective. So next slide, please. There's a few realities you have to keep in mind. I guess I clicked that, huh? Yes, good. So not every doctor knows about every diagnosis, and that of course is going to be vastly more difficult when the disorder is a rare one. In addition, there are doctors out there who have very novel or very controversial opinions about certain diagnoses. So there may be a diagnosis that is well recognized, but a doctor has a different view on the spectrum of what it can present as. There may be a group of disorders that are well recognized, but some doctors believe in diagnosing certain patients that don't quite fit into that spectrum. And then there are diagnoses that kind of ran a course and had a big set of scientific discussion in which the traditional medical community no longer accepts that that diagnosis exists at all, but yet there are still physicians who practice in that area, making that diagnosis and prescribing treatment. We also have to recognize that there are people who do make their children sick or pretend that their children are sick in a knowing manner for reasons that often escape elucidation or clarity. These people do exist. We do encounter them. Finally, every doctor knows about that, but many doctors don't know much about that. So you can lump that in, perhaps, with the rare diagnoses. So I want you then to think about what the diagnosis or the perspective of a physician might be, considering that 80% of the work they do is made just by talking and taking a history. And I'm going to run through four different situations and try and say, let's just focus on that history, that initial impression, the doctor's eye view. So we'll take this diagnosis that may be unfamiliar to the doctor. There are children who have diseases that are not just unknown to the doctor, but unknown. And there is a special unit in Bethesda at the National Institutes of Health that see children to try and elucidate unknown diagnoses, when children are clearly ill, but no one can quite decide what they have or why. And then there are these controversial things, okay? So this doctor, if we're dealing with the unfamiliar, unknown, or undiagnosed, okay, not the controversial yet, the doctor's looking and he's taking a history, because he's a he, lots of doctors are she's. In pediatrics, more doctors are she's than he's now. But the doctor's taking a history and the symptoms just don't make sense. It doesn't add up to them. It's not like anything they completely are familiar with or that they know about or that they accept. But maybe they venture a treatment, okay, and it doesn't work. Okay? Or maybe the patient presents with a treatment, but they're presenting because the family is saying the treatment doesn't work. And of course, you don't know what you're doing, you don't believe in your treatment, or you're choosing something that doesn't work, and so the family eventually, hopefully, is going to kind of get fed up with you, and they're going to express that. So this is the doctor who's facing something where either the doctor themselves or medical science as a whole either is unfamiliar with or does just not know about at all. Now let's move over to the controversial disease. The doctor you're facing may know about the controversy or may have been just conventionally educated in conventionally accepted things and just be totally unaware that these thoughts exist out there. So once again, they're taking their history, and these symptoms and the diagnosis and what they're getting just don't make conventional sense to them because their thinking is conventional and their education is conventional. The treatments are either unconventional or are conventional and not working, or somewhere in between. And once again, the parent, having received this controversial diagnosis before, maybe having committed to this controversial diagnosis and treatment, is dissatisfied because you're telling me you've never heard of this thing, this is not how this is usually done, what you're saying this is controversial and we shouldn't be thinking this way. That's going to beget, naturally, parent dissatisfaction. A third case. In this case, the child's illness is actually misperceived by the parent. Okay? One of the things I tell residents when I'm training them is that from the doctor's eye view, every patient presents too early or too late. None of them, from the doctor's eye view, presented exactly the right time. How many times do you take your child to the doctor, and they go, "It's nothing, just go home, just wait." Or you bring your child to the doctor and they go, "What, they had this symptom yesterday? Why weren't you here yesterday?" These are things we hear all the time, and I'm trying to tell physicians, hey, give the parents a break. It's easy to say they're too early or they're too late. But what if the patient is coming in over and over and over again, and the doctor doesn't see something there? Okay? Or the child has a known entity, is being treated for their known entity, but the parent seems to be over-reporting symptoms, or seems to be reporting symptoms and blaming it on the entity when that's not part of the spectrum of the disease. So in this case, what I'm proposing as my postulate is that this parent is misperceiving the condition of their child. They've been sensitized in some way, they have some worries or beliefs, and they are manifesting in their perspective of their child's disease that may not be accurate. Again, the symptoms the parent is saying or reporting may not make sense to the physician. Treatment may seem entirely inappropriate, or the treatment that the parent is seeking may seem inappropriate or not make sense. And again, the parent in perceptions, and so faced with this physician, the parent is going to be dissatisfied. Now we have a case, and that is the case of fabricated or induced illness. There's an important difference between this case and the prior. This parent knows they're propagating a falsehood. They're either propagating a falsehood by creating false statements that they're sharing, or by actually inducing illness in their child. So this child comes in with fabricated or induced illness, and again, what we're being told doesn't make sense. It doesn't make sense from conventional medical understanding, or it doesn't make sense from the child we're seeing in front of us. The history doesn't make sense. Treatments don't work because the parent does not want treatments to work. They want to continue to perplex and seek more treatment, more diagnosis, and saying, hey, this works, may only be a temporary phase before coming back and saying, no, that's not really working, we need to do something more. And then finally, the parent comes back until you say no more, and then the parent is dissatisfied. So I hope you can see that these four situations, hypotheticals, have some similarities in how they would appear to the physician. And so the physician, listening to the caretaker, looking at the child, then may turn around and say, maybe I don't know something, or maybe medical science doesn't know something. But maybe these people have kind of bought off on some sort of controversy that I'm not buying it, okay? I'm not buying the pandas, or I am not buying chronic Lyme disease, which has been overwhelmingly rejected by the conventional medical community. Okay? I'm not buying it. Or they may say, this lady's well-meaning, it's usually the mom, right? Because who gets to bring the kid to the doctor? The mom, right? Who is most of our audience? It's moms. So looking at the mom and saying, she's got a tough road. This kid's got something going on, but she's a little crazy and me stuff that just does not make sense. Okay? Or then finally, and most concerning of all, the doctor may say, I think she's making this up. What is she trying to pull on me? What is she getting out of it? Or worse yet, she's poisoning her child. She's harming her child. So the doctor is looking at these four things, and all of them lead to histories that just don't make sense to them. The case is not folding together as they were taught in medical school. Okay? All of these cases, there's dissatisfaction on treatment options. They're not working, or unconventional treatments are being sought that the doctor does not endorse. And all three, the doctor is anticipating or experiencing conflict with the family. And let me tell you that if you want to find a bunch of conflict-avoidant physicians, talk to pediatricians. Okay? Surgeons thrive on conflict. Internists, it's no biggie to them. Pediatricians want to be loved. Okay? And so they are conflict avoidant. And so now they're looking at this and they're going, holy crap, this is a black box. I can't figure it out. How am I going to separate these people out? And most importantly, how am I going to separate these people out without getting in a fight? And so this is them. They're confused, which means they're uncomfortable. Okay? And they have three options. Try and resolve the situation themselves. Call a consultant, that's me, or just run from the door screaming, give you what you want and send you on your way. That's their options. And you know what? None of these are satisfying. None of these are satisfying. So, you know, these doctors want to do the best by you and your child, but they're having a hard time perceiving what that is. Do they need to get you to the super subspecialist or give you what your super subspecialist has already been giving you because you've got a rare disease that they just don't know about? Okay? Do they need to hold your hand and help you see where you're a little bit off and that we can just work this through together? Or do they need to catch you in a lie or catch you in something worse than a lie and get you to DCF, since this is Massachusetts, it's DCF here, and get you, managed so that your child can be protected? What do they need to do? All right? So this is a recipe for trouble, which I call entering the dragon. Okay? I did not make that up. It's probably from some sort of Bruce Lee movie. All right? So I now want to differentiate between three terms, and frankly, we're going to throw a few more in there before we're done. Okay? The last speaker talked specifically about medical child abuse, and I want you to know what medical child abuse is defined as and what its history as a diagnosis is. I didn't come in at the beginning, so I may have missed. Someone may have talked about caregiver-fabricated illness. And then there's the ever-popular Munchausen syndrome by proxy, who people who are historians think the Baron von Munchausen is being totally maligned here by being associated with this. And I've driven through the town of Munchausen. It is nothing to write home about. So first, let's talk about medical child abuse. So the history of medical child abuse. Medical child abuse comes to us from really a married couple, Tom Ressler and Carol Jenny. They started talking about this in educational sessions and then wrote a book. As I see it, the effort of diagnosing, creating this entity, which doesn't seem to, my slide doesn't seem to have advanced, right? The purpose in creating this new idea, this new name, was a little bit to restore. I see that you're going to have a question, but we're going to have to wait for the thing. Yeah. So they seem to have wanted to broaden the spectrum to help more children while accusing fewer parents of really bad things. Okay? So in a way, the medical child abuse diagnosis is a bit of a step down, maybe a lot of a step down from Munchausen syndrome by proxy, which we'll get to, but does include Munchausen syndrome by proxy. And so what medical child abuse says is that the child is over-medicalized, is receiving medical treatments, diagnostic procedures, attention, is being given diagnoses, and is receiving not just medical treatment, but treatment in the home, treatment in the community, that is not warranted. It is not warranted. Missing out on recess, or rolling around in a wheelchair, or getting your coenzyme Q, or your long-term antibiotic treatment, or something like that. The concept is that in this patient, that is not warranted. Okay? Now, the way it was written, it's received because the kid is being brought for care. I got to say that sometimes this is really totally the doctor's fault and not the parent's fault. Okay? But the way it was written, it's kind of laid at the foot of the parent. And that harm is actual, or the risk for harm has been made significant by the receipt of this care. Whether that harm is psychological, merely because this child is being raised in a sick role that is going to distort their view of themselves and their view of their health and their view of the world, or whether the harm is much more evident, like going under repeated surgeries or being put on potentially toxic cocktails of medication. So this is a very broad definition. It encompasses false diagnoses of controversial diseases, caregiver misperceived illnesses, fabricated or induced disease. Okay? It encompasses all of these things. The next diagnosis, so this diagnosis, by the way, has never been in any diagnostic system. It was never endorsed by the American Academy of Pediatrics or picked up in any of the AAP's real writings, except as we'll mention. It was never part of the ICD-9, the ICD-10, or the DSM, the Diagnostic and Statistics Manual of the American Psychiatric Association. It's not really a codified diagnosis. It has no code. Okay? But it was picked up a lot by the child abuse community and probably misunderstood and misused a certain degree, having read the whole book myself, which is way overpriced, by the way. All right? The next thing is caregiver fabricated illness. This is the term that is in the most recent American Academy of Pediatrics statement prepared by the Committee on Child Abuse and Neglect and published in Pediatrics. Okay? What happens in caregiver fabricated illness is that the caregiver presents the child for diagnosis and treatment fully knowing that the child does not have the symptoms or causes of symptoms that they present. Okay? So these people are knowingly deceiving the clinician, either by creating an illness or by lying about symptoms. The motive, as this is defined, is immaterial. So that if you're fabricating an illness so that the doctor will say your ex, the bastard, doesn't get time with your kid, or whether you're fabricating the illness because you want some SSI, Social Security insurance, or whether you're fabricating the illness for whatever psychological satisfaction it gives you, this term applies. But the mental state of the caregiver must be one where they know the child is not ill. What has fallen off here, is misperception. If a caregiver genuinely believes because a doctor told them or because they read it on the internet, that purveyor of all fine information, or because they just have their own belief. Maybe they don't know a diagnosis, they haven't researched it, but they just really believe something is wrong with their child. That is not caregiver fabricated illness. That is something else. Okay? And there is no really good codified diagnosis for that. The final thing to talk about is Munchausen syndrome by proxy. So you see the list of reasons why this caretaker may be fabricating an illness: sympathy, financial gain, associated assistance like home care, things like that, for advantage in the legal system, perhaps in a divorce battle, or for ill-defined psychological reasons. If we defined it merely as by the ill-defined psychological reasons, then we're at Munchausen syndrome by proxy. Okay? So the classic formulation is, quote, to assume the sick role by proxy, having dealt with some real cases, which is the minority of what my opinions generally be. Most of my opinions end up being the doctor did not know what they were talking about, or something more complicated is going on here. But in real cases, it's kind of hard to say what this sick role by proxy is. There does, however, seem to be a real desire to fool authority figures, okay? And some literature on looking at the rest of the relationship between the child and the fabricating parent suggests that there's actually a general hostility to the child, okay? So Munchausen syndrome by proxy has a very specific psychological component to the diagnosis, which often brings in a psychiatrist. Fabricated illness kind of broadens the psychological components, all right? But requires that the parent or caretaker be fully knowing of fabricating or inducing the illness. Whereas medical child abuse, as I said, it was supposed to be kind of a kinder, gentler term, but in so doing became a much broader term, does not worry about whether the caretaker knows that they're propagating a falsehood, merely insists that they be wrong and that that result in care that is actually or potentially harmful. Okay? So that's the situation. All right? So if I said we're entering the dragon, okay, now my question is, how can our gallant knight sally forth and avoid the dragon and not get toasted? Okay? How can that happen? And so what I want to talk about now is kind of following up on that last lecture, which gave some very good advice on what could help the physician, from the physician's eye view, at least keep that differential diagnosis open and not jump down into the dragon hole. What can do that? Okay. So, a truly genuine diagnosis that is unfamiliar to our good-looking and exceptionally young hero here may have certain characteristics that will help him in this case, her in more cases, realize that that's what's going on. The first of these is objectively confirmable findings. Okay? So, if someone has given you a diagnosis of chronic Lyme disease based on a Lyme titer that is known to be a garbage pail of a lab test, not so good. If they have a Western blot, a little bit better. It's a better test. Okay? If someone has given you a diagnosis of Ehlers-Danlos syndrome, and you have some gene studies that show abnormalities of a form of collagen, we're in good diagnostic shape. The problem is there are genuine cases of Ehlers-Danlos syndrome for which there is no laboratory test. Okay? If your doctor has given you a diagnosis of mitochondrial disorder, and there's been a muscle biopsy, which is hopefully becoming less and less frequent, and you have ragged red fibers or one of these other things, or if your gene tests, autosomal and mitochondrial gene tests, show a gene abnormality, then we have an objective finding, okay? And we merely need to wave that under the nose of our confused young doctor to say, I need to be thinking about things. The problem is, what if there are mitochondrial disorders that lack these tests? We know there are Ehlers-Danlos types that lack these tests, okay? And so the problem is that this won't always do something. But there's also imaging findings, right? So there's imaging findings. Maybe there's a cardiomyopathy and we can see it on echocardiogram, or there's something abnormal in the brain and we can see it on an MRI scan. There's also physical exam findings, so that if your doctor can do a Bateman test and do a score of greater than 6, okay, at least they're going to be willing to consider and maybe should absolutely accept, hypermobility type Ehlers-Danlos syndrome. That doesn't mean they're going to accept it causes fractures in infancy, which is the controversy, and I would say manufactured controversy from my perspective, but they would at least accept that. The diagnosis is genuine. But what about the disease? It's just like aches and pains or vomiting or these episodic conditions, seizure, breath holding spells, episodic fainting spells, vomiting, these things that are episodic. So if the only person seeing and reporting these is the caretaker or someone under the caretaker's thumb, the doctor's going to have a harder time accepting this as being an indication of genuine disease, okay? But if they're independently confirmed by unrelated people, teachers are seeing it, okay? It happened in my other doctor's office, okay? These things, independently confirmed subjective findings, these are going to help the doctor believe in the diagnosis that they don't necessarily know, okay? Or maybe no one knows, and maybe send you to Bethesda, or find the super, super duper subspecialist, which I know doesn't make people happy, but often takes you to Boston Children's Hospital. Okay? If there is literature, if you've got literature that's in a good peer-reviewed journal with a high hit point value, keep it in your purse, okay? Or at least keep it with you when you go to see doctors. Because if they go, this doesn't make sense to me, I'm not quite figuring it out. Say, yeah, it didn't really make sense to us, but my doctor gave me this paper and it seemed to fit my child. This is kind of what we've been working with, all right? Something like that. And then finally, if the doctor who diagnosed you is widely known, does not have a controversial reputation, and has clearly documented their diagnosis, that may help. That may help. None of these things is perfect. What about the controversial disease? So remember, the symptoms don't make conventional sense because the explanation is not conventional, okay? The treatments that are being suggested are not conventional, and the conventional treatments don't work. So what about this? Once again, we've got the same thing. At least if there are objectively confirmable findings, the doctor may not accept the controversy, but has at least to accept that the child has something going on, or at least has to consider that the child has something going on. Trouble will come in the 4th slide, okay? Again, if the subjective findings are confirmed by someone who is fully independent of the caretaker, the doctor has to consider that something may genuinely be going on, okay? And finally, if the parent knows about the controversy, is open-minded to discussing it, and is very concerned about avoiding the harms which the doctor is trying to avoid, whether those be psychological harms or medical harms, okay? That attitude, that I'm going to engage with you. You don't think that this is right? You don't understand the controversy? My other doctor really did. Could you two talk? I thought that was a great suggestion. And we'll get back to the medical child abuse book eventually. Okay? But that kind of an attitude as opposed to you're one of them. How hopelessly conventional of you. Get me out of here. That's not necessarily going to go down well. Okay? Now, if you can successfully escape, not going down well may not be a problem. Okay? But depends on how big your dragon is, right? And what state in our proceedings we're at. For caregiver misperceived disease. Okay, remember, the doctor now thinks that you're either a little oversensitive, somewhere between a little bit oversensitive and overconcerned, and downright crazy. Okay? The goal is to not look crazy. All right? So that if you have a child-centered view, you say, look, my child says this. My child does this. This is why I'm worried, is because this is what I see in your child. Okay? Can you help me with this? I don't want to do anything wrong. I don't want, I'm not wedded to believing my child is sick. I would love nothing better than to walk out of here with a well child. Okay? I'm going to be open-minded. I'm going to consider. And primo, let's avoid doing anything that's going to harm my child. If you don't do tests just because you think you're trying to get rid of me, and don't give me antibiotics just because you're trying to get rid of me. Do you really believe this is going to help my child? Okay? Child-centeredness, a willingness to consider the possibility, that maybe I'm a little sensitive. Yes, I've been made sensitive. This child has just been such a challenge to me, and I love them dearly, but I don't want to harm them. That attitude will win you a lot. Then we get to the fabricated or induced disease. Now, these are not very, very common, okay? But when you've got a rare disease and you gather in societies for parents with real disease, these people come and commingle with you, okay? And they are real, okay? So what do they do that complicates your thing? The objective findings may be absent, okay? But they can also be produced by tampering with lab tests or by poisoning children, okay, or harming children. There's a famous old, well, it may not be famous because it's old and doctors keep getting younger every year, okay, but there's an old letter to the editor of Pediatrics, "My Mother Caused My Illness," where the woman, now an adult, describes how her mother used to kind of hit her on her extremities with a hammer to produce these red welts and then present them as spontaneously occurring things. Okay? So induction of illness by assault or by poisoning, okay, or tampering with tests. So the child is not harmed, but a little blood is added to the urine or to the stool, okay, or something is done to the lab tube. These things create the appearance of objective findings, and that's why having objective findings isn't always enough unless they make some sort of sense. Okay? Once again, these families, the subjective finding is either unconfirmed by an independent person, or eventually, as the child gets older and has been raised within this belief system, the child can adopt those beliefs and adopt sick behaviors. And those things get seen in the school. So even having an independent observer who says, oh, I see these symptoms too, if the symptoms can be what we call functional, okay, where they come from something other than the genuine disease. Things like just staying in the wheelchair, having no energy, okay, being distractible or tired all the time, all the way up to pseudo-seizure, where children act as if they have seizure when there's really nothing electrical going on in their brain. These are functional things, and they create problems because they can create subjective findings seen by outsiders. Okay? But this family genuinely wants to continue the medical charade. And so they will find a way, if they're very graceful, you may not catch on to it, but they will find a way to walk away from the opinion that their child is not ill and find their way back in to some other doctor's office who is willing to continue the search and the treatment. Okay? So these are how these things are then differentiated. And I hope it's recognized that it's not perfect. There's still a lot of overlap, even when you throw this in. And the job is genuinely hard. So I already told you, I know that Carol Jenny often gets booed or hissed in some audiences, but the purpose of publishing the medical child abuse book, as I saw it, was to broaden the diagnosis to help more children while stigmatizing fewer parents. But that book also had a method. What are we supposed to do when we are our confused doctor? And the first step in that method is to get all of the medical records together so that we're considering all of the medical opinions. And the second step is to try and bring the doctors together, okay, so that in those cases that were mentioned in the last lecture, the physicians from the other hospitals would be brought into conference with the physicians from the current care team, and they would have a discussion, and they would say, how can we resolve this difference of opinion? That is an express recommendation of the book. Okay? So the book did recommend that. And it would help you to kind of know that. You know, rather than burning this book, it might be good to tear out that chapter and put it in there with your journal article to have with you. Okay? So this is just kind of a quickie tour. I didn't want to do too much. I kind of wanted you to see how doctors might look at things, the diagnoses that they have to consider, including some that you do not want labeled on you and your child, and then the things that might help doctors see the difference. I would say that if your child has a false diagnosis, and that diagnosis is leading to treatment, broadly construed, treatment in society, treatment in the home, and medical treatment that is potentially harmful to them, you know, we need to find this diagnosis and it needs to be roasted. Okay? The dragon has a purpose. The dragon has helped or saved children. But for most of you, what you need is to take this guy and take his uncertainty, take his confusion, and kind of shrink it a little bit. Let him say, maybe I'm not so uncomfortable because there's a process I can go through. And that we can tame our dragon and walk away with a child who may not be fully healthy, but is at least well as their disease process allows them to be. So that's it.